Every year, about 600,000 patients are admitted to general surgery wards with abdominal pain. And that abdominal pain will have a multitude of different causes. But amongst those is going to be acute bowel obstruction, which is defined as the inability to pass gut contents through in a timely manner, an obstruction to the passage of bowel contents. And that's a surgical emergency. And unless it's picked up quickly, then those patients will develop severe complications, or they might even die. The study advisory group was convened, which really helped define the study aims and objectives, the things that we really wanted to know about this population in order to look at the quality of care that they were receiving. Once that had happened, we used standard NCEPOD criteria to identify a study population. So we used ICD-10 codes to look at those patients that had bowel obstruction, and then approached individual hospitals for a maximum of 10 patients per hospital. We didn't want to overwhelm any particular institution. And we selected within those 10 patients the ones where the most acutely ill ones. So in order to stress test the system. So of the 10, 2 patients were treated medically, 4 surgically, 2 of the 10 ended up dying of their disease, sadly, and 2 patients had at presentation or developed acute kidney injury. So we ended up with 668 patients, which we could review, and 71% of those presented with small bowel obstruction, the remainder with large bowel obstruction. They were quite a frail population. 3/4 of them were over the age of 60, and over a third had a Rockwood frailty score of more than 5, so significantly frail. 82% of patients presented via the emergency room. 63% of them presented with pain, and just over 1/4 of them already had acute kidney injury at the time of presentation. In almost 90% of patients presenting to ED, their basic observations were pretty good, but only 57% of them had a pain score recorded, even though most of them had presented with abdominal pain. Only 23% had their hydration status recorded, and only 11% had a nutritional assessment or even their weights done and body mass index done in ED. When they were treated in ED, only 13% of patients were treated according to a protocol for acute bowel obstruction.
Making the diagnosis of bowel obstruction early in the pathway is really important, both to allow the patient to be managed by the correct clinicians looking after patients with bowel obstruction, and that is surgeons. We've recommended that surgeons should look after these patients. The way to do that is to do a CT scan as early as possible in the patient's pathway, and that allows them to be diagnosed with bowel obstruction and referred to the correct specialty, which is surgery. The CT is also important because it will identify potential complications which, if the surgery is delayed, will result in a poorer outcome for the patient, such as bowel ischemia, bowel perforation, and this can, in some cases, lead to death if the patient's not treated in a timely manner. The study found that there were a number of delays in the process, both in getting CT with intravenous contrast and in the initial assessment by a consultant in some cases. So CT was delayed in 1/5 of cases. Some of these were due to access to radiology, and some of the delays were due to consultant review, and also being admitted under the incorrect specialty, which was most commonly the medical team. One of the other delays that we found was a delay in access to theatre, both due to lack of theatre availability and lack of anaesthetic availability. And these delays can sometimes, in a few patients, result in poorer outcomes. Decision making in terms of once a decision has been made to go to surgery was quite good in the study, contrary to what people in the study advisory group thought might be the case. So timely decision making about operating was quite good. However, we found that decision making in terms of risk assessment and frailty assessment was not so good in some cases. Now, the reason for frailty assessment and risk assessment is that it allows clinicians, family and patients to have a multidisciplinary discussion and a shared decision making about what the best method of treatment for patients is. And we found that quite a lot of the patients in the study, nearly a third, had a frailty score, a Rockwood frailty score of 5 or more, which is moderate to severe frailty. We found in the study that frailty had an association with a poorer outcome. So patients who had a lower frailty score between 1 and 4 had a lower mortality, around about 3%, and patients with a score of 5 or more had a 37% mortality if they underwent surgery for acute bowel obstruction. So this is a significant difference, and this is something really that needs to be explained to patients. Frailty also is an indicator of poorer outcome after surgery in terms of quality of life, and that's something that we believe should be discussed with patients, and we've recommended that frailty scoring should be done in patients over the age of 60 who have acute bowel obstruction. Mortality scoring or risk scoring for surgery is something that was not done that well, with about a third of patients having mortality documented on their consent form. And we would think that in an operation where the mortality can be as high as 10% on average, that this sort of thing should be discussed as part of the consent process and the shared decision making. We also found that some of the alternatives to surgery were not discussed in a reasonable proportion of patients. It was found that by the reviewers that about 45% of patients had inadequate risk assessment. And so we think that risk assessment should be improved, as well as frailty assessment, to allow us to have the correct discussions with patients about how they would like to be managed. And also it gives us the ability to make decisions about where they should go post-operatively, such as the intensive care unit.
So in patients presenting with acute bowel obstruction, and especially those going for a surgical operation, it's not surprising that nutrition is a really key issue. And yet only 41% of patients had an adequate assessment of their nutritional status. And by adequate assessment, I mean either a MUST score, that's a malnutrition universal screening tool, or probably better, a review by a dietitian. And on discharge, going home, going back to the community, 37% were given some advice about their diet going forward and a plan to make sure they were eating. And that clearly is an issue.
The study really found that there were delays at various stages in the pathway of the patient care, starting on presentation in the emergency department and right through until patients were treated or had an operation. As a result of that, the care, as graded by our reviewers, was good in 55% of patients, but in 45% of patients, that's nearly half, there was room for improvement in the quality of care. And our main recommendation, or the overarching recommendation that we've made, is that there should be a pathway for care for these patients that improves the speed of diagnosis, management and treatment of the patients right the way through from when they're admitted until they're discharged. As part of monitoring that pathway, we've suggested various measures, including time to CT from presentation, time to diagnosis from presentation, and time to operation start from decision to operate. These measures will give hospitals an idea of how they're performing against the pathway, and the pathway should include all other 10 recommendations that we've made in the report.